All right, let's talk about herpes and pregnancy. 15% of age 15 to 50 women have HSV2 infection. HSV is a double-stranded DNA virus. Incubation period is around 1 week. Antibody development um, you will start having antibodies in 2 weeks. Viral shedding will go on for 15 days after the outbreak, and there can be cervical shedding as well. Non-primary first episode, patient already has infected with one subtype, then have a first outbreak from another subtype. 2% of pregnant patients have HSV infection. 1/3 of neonatal herpes are caused by HSV1. 75% of women with genital herpes can expect to have at least one episode during pregnancy. 15 will have a prodrome or recurrence at delivery. 15% will of the first episode infections are actually recurrent infections. Neonatal herpes, the risk of vertical transmission when the first outbreak is during delivery is 80%. 25% of the neonatal herpes is disseminated. 30% of these cases will have central nervous system disease. 45% of these infants have diseases limited to skin, eyes, and mouth. 20% will have long-term neurological sequelae. Primary outbreak in the first trimester is associated with neonatal chorioretinitis, microcephaly, and skin lesions. Diagnosis: if there is a lesion present, virology test is preferred. PCR is 5 times more sensitive than cultures. Primary lesions more likely to result positive results versus recurrent lesions, 80% versus 40%. Universal screening is not recommended. So treatment, acyclovir is a nucleoside analog, and it enters the virally infected cell, inhibits viral thymidine kinase and DNA replication. It can cause neutropenia, but it is transient. Can be administered IV to pregnant women with severe genital herpes infection or disseminated disease. Patients with first episode during the pregnancy or history of genital herpes should start suppressive therapy at 36 weeks. If first outbreak in the third trimester, they should continue therapy until delivery. Primary or first episode infection, you can do acyclovir 400 milligrams TID for 10 days or valacyclovir 1 gram BID for 10 days. So 400 TID or 1 gram BID for 10 days. Recurrent, you do acyclovir 400 TID for 5 days, or valsaclovir 1 gram daily for 5 days. Suppression, start suppression at 36 weeks. Acyclovir 400 milligrams TID until delivery, or valsaclovir 500 BID. If you have severe disease, you can do IV acyclovir 5 milligrams per kilo for every 8 hours for 5 days, then oral for another 5 days. Valsaclovir is safe during breastfeeding. Acyclovir is found in the breast milk, but it's only 2% of the therapeutic dose for neonates. Delivery, C-section, if active genital lesions or prodrome symptoms in the 3rd trimester, such as vulvar pain or burning. However, C-section does not completely prevent vertical transmission to the neonate. You still has a 1% chance of getting neonatal herpes compared to if you did vaginal, it's 10%. So if the woman had primary or non-primary first episode of genital herpes in the 3rd trimester, C-section can be offered. If the lesion is not genital, we can cover the lesion with an occlusive dressing, so we don't have to do C-section. If the patient presents with ruptured membrane, or if they have prodromal symptoms or active genital lesions at term or near term, C-section should be performed ASAP. However, if patient presents with PPROM, there is no consensus. So we can have if expectant management is chosen, then antiviral therapy should be started. CVS can still be done with genital lesions. In terms of breastfeeding, unless there is an active lesion on the breast, breastfeeding should be continued.